All right, guys, thank you very much. My name is Alister Martin. I'm a PGY3 resident at the Harvard MGH and Brigham program. And I want to tell you what we're doing at MGH to help solve the opioid epidemic. Before I get there, though, I want to tell you a story. I was a first-year intern in my first month in the program and had a woman who came in who was in her early 30s. She had 2 kids, and about 2 or 3 months prior to coming in, she'd fallen. She was taking her kid down the steps at her son's daycare center and actually broke her ankle. Had a huge, extensive right ankle fracture and had to get an open reduction internal fixation. She was started on oxycodone, and over the course of the next several weeks, she felt she could not get better without the medication. She couldn't feel normal. She started taking medication from her friends, from her family, and then went back home to her neighborhood and actually got a dealer to help sustain her habit. Over the course of that night, she had come to a conclusion that this wasn't for her. She had 2 kids. She had a life. She shot a message to her dealer and said, "I'm done. It's over. Don't contact me. I'm getting help." The dealer surprisingly responded, "I get it. You're right. Good luck." An hour later, she heard a knock at her door. She went downstairs and it was her dealer. He had 10 free teal oxycodone tablets for her on the house for being such a good customer. She took them. Thankfully, her husband brought her in and brought her to me. And I was excited. I wanted to bring her into the hospital, get her treatment, get her an addictions consult. My attending looked at me, though, and said, "That's not what we do here. We detox these folks, discharge her and give her a detox paperwork." Now, it's not just me who's frustrated. It turns out that if you ask emergency medicine physicians, 87% of us around the country say, we are fed up with this. The opioid epidemic is not getting any better. In fact, it might be getting worse. Over the course of the last 10 years, we've seen a 100% increase in opioid visits. When you ask us, 93% of us say that we use detox for patients with opioid use disorder. Now, why is that a problem? Folks who get detox die. 20% of folks who were in a randomized control trial didn't even make it through the study. 0% of them stayed in treatment. So medication treatment in the ED has some value here, guys. It's a partial agonist, so the overdose risk is low. Its misuse potential is low, given that it's got naloxone in it. And it's got over 30 years of addiction medicine research that shows it's a gold standard. Here's what happened in France. In the 90s, France liberalized its buprenorphine practicing guidelines, an 80% drop in heroin overdoses. On the right, when you take people and put them on buprenorphine, 42 months later, 90% of them are in remission. Of course, we know Gail D'Onofrio's study, she spoke about it earlier today, randomized control trial showed that when you start people on buprenorphine in the ED, 78% of them get better and stay in treatment. 37% in the control group do not. Now, we had 2 big challenges to trying to do this at our shop at Mass General, and within each one of those challenges were opportunities. The first challenge was current federal law. The second challenge was that there was no pre-existing buprenorphine protocol we could just grab off the shelf. So that first challenge, current federal law states that every one of us here in this room, if we want to prescribe buprenorphine, we've got to take an 8-hour course and we've got to pay a course fee. No other medication in the world is like that. So what we did for Get Waivered was we started with 1 physician in our Mass General ED who had a waiver, and we wanted to increase it to at least 90%. But we wanted to do it without making it mandatory. So we recruited a team of behavioral science experts, public policy students, and designers, and launched a behavioral economics framework to help folks make the decision to get this waiver. So we built a seamless website. We made access to treatment or to the training sessions easy. We invited a local news station, NPR, to come and cover the story, and we got earned media write-ups about it, highlighting our work. Now we're at the end of the campaign, and we've got 41 out of 46 of our department folks who have waiver in hand. That's 90% of our department who's got that. We've been asked by the NIH to help replicate this model nationally, and we've been invited as consultants across the country to help set up a similar system. But our second challenge was there was no easy buprenorphine protocol to sort of grab off the shelf and start. We were sort of looking at a blank slate. So what we did was we created the nation's first coordinated ED-initiated buprenorphine protocol, coordinating ED and the Bridge Clinic, which is an addictions medicine clinic. We wrote about it with academic pieces, we wrote about it with policy position pieces, and we launched a protocol which we are happy to help anyone in this room, if they're thinking about exploring buprenorphine out of their ED, to be a help for that. Our protocol, 24/7 access for anybody who needs it, whenever they want. Second, we get folks 2 days' worth of medication in hand, getting around the prior authorizations and getting folks out of the pharmacy wait, and everybody gets follow-up the next day. Guys, this is our opportunity to lead. Emergency department providers can lead on this, and if we're going to get over this crisis, we absolutely have to lead on this. Get waivered, explore ED-initiated buprenorphine out of your shop, and think of the ED as the front door to treatment. These folks need it. Thank you.
Thank you so much. Adam Benzing? Judges?
So, thank you. Excellent presentation. Have you done sort of long or intermediate term outcomes for your patients in your study? Thank you.